Hi everybody, a very good evening to all of you. Looking forward to have a good interaction with all of you in this session. Okay, so hope you guys are doing well. So as you know, your favorite subject, pharmacology has come up now. So without any further ado, let's get started. Now, as you know, the basic idea is that these are the topics from which you can get the questions. I have tried my best to give you a bit of a tougher language so that you practice it right now. And in the exam, if this kind of a question comes, you should be easily able to answer. Relatively, in the exam day, the questions are going to be on more easier side. Okay, so don't hype up the exam too much and be anxious. I know this is quite easier to be said than done. You must be saying, sir, you are not the one taking exam. Obviously, we will have anxiety. It's true. But how much anxiety will increase depends on your attitude towards the subject and the exam altogether, right? It is just another GT that you're taking on a more serious note. If you have already practiced that, it will be okay. Let the fear happen. Fear will keep pushing you, keep you more active. Unlike the classes, you will not be sleepy on that day because of the fear. So let the fear happen. I'll be happy for that. Okay. Chalo, let's go. Anyway, now the drill is I'm going to put up the questions, and following that, what you have to do is 1 minute will be given. So here we go. The first question is, a 36-year-old male presents to your office for a routine checkup. He reports that he's concerned about his blood pressure after receiving a reading of 155/100 mm of mercury during the general checkup. Although the patient has been exercising regularly after that reading on the examination, now he has a blood pressure of 164/100 and the heart rate is approx 90 or something. You prescribe metoprolol and the schedule. All right, everybody, welcome. I really hope you guys were able to listen to me what all I was saying earlier. In case not, never mind. We may get started right here. There was some issue with the buffering of the video. So hope I'm right now visible to you all and audible as well. You know, this kind of things are expected when the technology comes into play. All right. So anyway, this is the question that you're looking at, my friends. See, before we begin, let me just repeat that in case I was not audible earlier. See, when you see big questions like this, do not panic. Always look at the last 2-3 lines of the question first. A lot of times the real question is hidden in those last 2-3 lines. Okay. Now I'm giving you the hints because today I want you to practice and make mistakes, and tomorrow in the exam the same mistake should not be repeated. The reason of me conducting this session like much closer to the exam is this only. You all know pharmacology is volatile. That is the reason I'm trying my best. We'll take this session now and you may refer to it later also one more time before exam and you should be good to go. This 25 topics are definitely high yield, and from this definitely you'll expect a decent amount of questionnaire in your exam. Okay, so don't make exam a hype. I'm giving you much more difficult and longer questions over here so that you practice here. On the day of exam, God willing, it's going to be much more easier, relatively easier paper. Okay, so chaliye, let's get started with the very first question. Good to have all of you in this session. A 36-year-old male presents to your office for a routine checkup. He reports that he is concerned about his blood pressure after receiving a reading of 155 systolic over 100 diastolic mm of mercury during the general checkup. Although the patient has been exercising regularly after that reading on the examination, now he has a blood pressure of 164/100 and a heart rate of 92 beats per minute. You prescribe metoprolol and schedule a follow-up appointment Which of the following changes do you expect to occur as a result of this therapy? So this is the question. Okay, so I can see many of you are falling towards the correct side. You all are saying that beta 1 is also present on the JG cells of kidney. Now what happens because it is present on the JG cells of kidney? The idea is that when you block beta 1 receptors, the renin levels will reduce. And when the renin level reduces, this will lead to blockade of RAS indirectly, correct? So this is the simple logic. The correct answer here to this question will be simply there will be decreased levels of circulating renin. Okay, decreased levels of circulating renin. See, I told you during our classes that the word peripheral vascular resistance, you can simply translate that to blood pressure, PVR, or systemic vascular resistance. Okay, so peripheral vascular resistance, systemic vascular resistance, these are all the fancier words, or total peripheral resistance, right? These are all the words for BP. When I'm giving you a drug called antihypertensive, it should reduce BP, na sir. How can it increase BP? So this is a wrong option. This cannot be true, right? Beta blockers are not vasodilators. I told you beta blockers, they reduce the renin. That's how they will be producing their effect in the blood pressure. Beta blockers also work on the heart because they block the beta 1 on the heart. Again, they can reduce the blood pressure. So they are having a different mechanism, right? Logically, this is the correct answer here. Now, one more thing that I want you to know is there are certain drugs called DRI, direct renin inhibitors, right? These are the drugs having iron in the name, or kirin, right? They end with kirin, iron. Iron means they inhibit renin. Now the question is that the drugs are clearly saying that we inhibit renin, but in the exam day you will be surprised to see something that they actually increase the levels of renin. It is happening due to some feedback mechanisms. All right. Now let me tell you one simple concept, right? See, there is a thing called angiotensin 1 that gets converted to angiotensin 2 by this enzyme called as ACE, right? So this is an enzyme, angiotensin converting enzyme. Let's say by a medicine, if I block the ACE enzyme, I block this ACE enzyme, right? What do you think happens to the level of angiotensin 1? Obviously, they will increase, right? They are going to increase. They were supposed to move forward, but if you create a hindrance for them, obviously they will increase. Always remember this rule of thumb. Anything before the block will increase. I don't care how many substances are now present before this block, they are all going to increase. Okay, so this is the logic that you must know. And based on this logic, direct renin inhibitors, name is renin inhibitor, but they actually increase renin, my friends. That question I don't want you to lose. These are some things that we may tend to forget before exam. That's why I'm just reminding you. Hope this is done. This is all over. Now, the next question, here we go. 43-year-old female comes to the physician because of a 3-week history of low-grade fever, multiple joint pains, and a rash. Her serum test is positive for the presence of antihistone antibodies in very high titers. The patient reports a past medical history of coronary artery disease, congestive heart failure, and cardiac rhythm abnormalities. The patient should be most likely on which of the following medications? Okay, so I can see a dispute that is happening between the option D and the option A. Okay, so two options I'm getting in here, option D and option A. Well, the correct answer to this is option D. Many of the people may have chosen amiodarone based on one logic that amiodarone is a drug that we use quite commonly for arrhythmia. It's a very wide spectrum drug. Yes, based on that you might have chosen. But sir, this is a question, this is what I do. I give you integrated questions because some questions come like this in the real exam. I gave you the word antihistone antibodies. So this was actually testing your pathology knowledge. Antihistone antibodies are seen in drug-induced SLE. Yes or no? This will be seen in SLE, that is drug-induced. Now, do you remember the mnemonic for all the drugs that may cause SLE? Mnemonic was shipped, okay, or at least the word ship. I told you S stands for antibiotics called sulfonamides. Sulfonamides are antibiotics. H for hydralazine, which is used in hypertension, usually in pregnancy. I for an antibiotic, isoniazid, used in TB. P for procainamide. P for procainamide, and D for dapsone. D for dapsone. So I hope all of you got this idea, sir. Okay. This is the simple logic that you all need to get it. Procainamide. Done. So this is the simple logic. Remaining SLE, you know the other antibodies like ANA, etc., etc. So antihistone are found in drug-induced SLE. Okay. Cool. So we have already discussed this. Usually you can expect one question from diuretic. Small topic. Don't lose this question, please. 67-year-old man with a history of CHF comes to the physician with fatigue and muscle weakness. Few weeks ago, the patient was started on a medication to treat her heart failure. Lab evaluation shows a serum potassium level of 2.2 milliequivalents per liter. The physician adds another medication to her regimen, and her fatigue and muscle weakness resolve. Her new medication most likely acts on which of the following nephron segments? Okay, so usually speaking, first you guys type in your answer. Which diuretic do we use in heart failure? Okay. All right, cool. Many of you are answering correctly, but I wanted to know like which diuretic. Okay, perfect. Spironolactone. Dr. Sai Vineet got it. Okay. Potassium sparing. All right. So basically, smallpox. You guys are all answering spironolactone. Awesome. Okay. So I like that name, Virat Kohli. Perfect name. Okay. So guys, spironolactone is the answer for this. See, understand the thing. Why is the muscle weakness, etc. happening? You all understand. Hypokalemia leads to these symptoms. So the doctor added another drug, they're saying. Already they have given the value of potassium also. Potassium is less. Normally it's supposed to be 3.5 to 5.5 approximately. It is less. Hypokalemia. So doctor must have added some drug to save potassium. That is a potassium sparing diuretic. We all know potassium sparing diuretics. Where do they work? On the number 4, collecting duct. Who works on number 1 area? This is the PCT. On the PCT, we got the diuretics called carbonic anhydrase inhibitors. Next, on the number 2, we got lupofenly. So loop diuretics will work here. Number 3, thiazides will work here. Okay, and then there is one more class of diuretics called osmotic diuretic like mannitol. And where does the drug mannitol work is? It works on both number 1 as well as number 2. But mostly it works on number 2. Okay, even mannitol works, more on the lupofenly. Okay, so I hope this is clear to all of you. So the correct answer is obviously number 4, as you guys were telling me. Okay, sorted with this. Now, this is a table like I usually give every batch that will get you at least one question from this table right there. Okay, so I'm going to share you this file anyway, you can read from that, so no need to worry about taking screenshots or this. The thing that we just discussed, like PCT, loop of Henle, DCT, which diuretics work there. Keep an eye on the names of diuretics, like carbonic anhydrase, we got acetazolamide, loop diuretic for, furosemide, torsemide. Thiazides will generally have thiazide, and there are some thiazide-like diuretics which don't have thiazide in the name, but they're thiazide-like only. Consider them as thiazides. Next is aldo blocker. If you block aldo, you will get potassium sparing effect. Okay, there are two types of potassium sparing diuretics. One is blocking aldo, aldosterone blocker. Second is ENaC blockers. And usually the mnemonic you got to remember for them is SEAT. Okay, how to remember this? You want potassium to stay in the body when you give these drugs. That's the purpose of giving them. You want potassium to be saved or spared. So when you want somebody to stay, you tell them, please have a seat, right? You want them to stay, you will say, please have a seat. So seat is potassium sparing diuretics. This is how you have to remember this. Okay. Next, after this, if you see the channels on which they work, that has been given. So this is a fact, like unfortunately now I cannot, make you memorize this or anything. You have to read this, how each of these drugs are working. All right. Next is at least the uses, meaning basic edemas, where to use which one. You should be thorough. For example, cerebral edema, if you go from here, cerebral edema, drug of choice is mannitol. Okay. Next one, if you go here, pulmonary edema, the drug is furosemide. If you talk cirrhotic edema, that's where you're going to use spironolactone. Mountain sickness, I believe most of you know that, it is acetazolamide. Correct? Next, if you talk about things like Conn's syndrome. What is Conn's syndrome? Conn's means too much of aldosterone in the body, hyperaldosterone. So when you have too much aldosterone, what do? Block aldosterone by a drug like spironolactone. So spironolactone is the drug of choice for Conn's, cirrhotic edema, and resistant hypertension. And ENaC blockers like amiloride, they are the drug of choice for lithium-induced DI or Liddle syndrome. Liddle syndrome is nothing but excess activity of ENaC. See, this is all interlinked with your medicine also, you all know this. But based on your answers, I am very satisfied. Looks like you guys are doing a good job. Okay, last one or two things I'll remind you in this. Loops lose everything. Remember this mnemonic? Loops lose everything. Whereas thiazides, they will save calcium. Thiazides, they will save calcium. That is the only difference. Okay. The remaining side effects are more or less similar when it comes to loops and thiazides. Okay. ACEs and ARBs can cause hyperkalemia as a side effect. That's why do not use them with other drugs who can also save potassium, because they can cause hyperkalemia leading to arrhythmias. So all these drugs, potassium sparing drugs, should be avoided with ACEs or ARBs because they also save potassium. So that's the thing, sir. This is where you can expect definitely a question. Okay. Let's move on to the next question, please. A 30-year-old male presents to the emergency room with complaints of high fever and generalized malaise. The patient has no significant past medical or surgical history. On further questioning, the patient admits to using illicit drugs IV on a regular basis. He is febrile and tachycardic. Auscultation of his heart reveals a faint murmur and presence of oscillar nodes were noted. Blood cultures reveal bacterial infection, and the strains isolated from this patient are known to substitute D-lactate for D-alanine in the synthesis of peptidoglycan. I know it's a long question. Which of the following antibiotics would now become resistant? First, before we solve this, I want all my friends to answer what case are we looking at here based on IV drug abuse, some murmur, etc. What are we looking at? Okay. The thing is, it is a case of infective endocarditis, right? This is a case of infective endocarditis. So that is done. Awesome. So what told me that this is infective endocarditis? The word like Osler nodes. Osler nodes. So can you guys type in which organism is the most common organism in IV drug abusers for this condition called endocarditis? Which organism is this? Awesome. Dr. Shakir got it. Staph aureus. Dr. Abhi Reddy. Great, great. Dr. Vibhan. All of you are answering the correct thing. So basically the most common organism is Staph aureus. And another organism that can cause infective endocarditis in the IV drug abuser is called Enterococcus. And the medicines to be used more or less for both of these organisms is going to be same only. Are you all understanding that? So it's going to be more or less same only. So now you check this out. See, let's remember it like this. There are organisms like Staph aureus or Enterococcus. I'm not going into the species of Enterococcus. There are species like Faecium and Faecalis again, and the treatments are slightly different for them. I don't want to confuse you with too many details at this point of time. Let's remember the juice of the story. Okay. Now we will simply remember the first type of drugs that we can use for these organisms. They are called penicillins. Okay. Precisely, Enterococcus will be using ampicillin. Ampicillin. All right. So I'm going to go for this drug right here, ampicillin. Now, you must all understand, penicillins comes in a type of drug called cell wall inhibitor. There's an antibiotic class called as cell wall inhibitor. Okay. Now, this cell wall inhibitors are divided into two types, beta-lactams, vancomycin. Okay. So, two categories. Cell wall inhibitor ही है, but there are two types. One is called beta-lactam, another is called glycopeptide, example vancomycin. Now this guy is coming under the class called beta-lactams, right? Penicillins are coming into the class called beta-lactams. Now imagine in Staph aureus or in this guy, if it is not working, meaning beta-lactam are not working, we can go for the next class of cell wall inhibitor called vancomycin. So the drug that is used for both of this situation here, it is none other than your vanco. So until now, all these drugs are cell wall inhibitors. Okay. Now that this is done, let's see. If let's say this is also not working, this is also not working, then we go for some other antibiotics which are not cell wall inhibitors, because this is also cell wall inhibitor, this is also cell wall. If both of them are gone, then we need to go for drugs which are like cell membrane inhibitor, example daptomycin, or a protein synthesis inhibitor called linezolid. Okay. By the way, I am sure you all have heard this word called MRSA here. And if vancomycin doesn't work, it's called VRSA. So what is MRSA? Methicillin resistant Staph aureus. So if you have a case of MRSA, then you have to give vancomycin. Next, same here, if penicillins are not working like ampicillin, we give vancomycin. And this word is called VRE over here. What is VRE? Vancomycin resistant Enterococcus. Enterococcus. So anyway, although the diagnosis there is endocarditis, most likely by Staph aureus because it's more common, still I'm explaining both the situations here. Answer is going to be the same for both. And if it doesn't work, we go for antibiotics like daptomycin or linezolid. Okay, daptomycin or linezolid, these are the antibiotics, same ones I'm going to use in both the situations. Okay, now this is what you must keep in mind. Clear? Now let's try to understand what was the question asking you. The question was asking resistance mechanism. Okay. Now pay attention to what I'm saying. If you have a strain of MRSA, why is methicillin not working? I mean, why is the penicillins not working? The answer is the bacteria may have changed or mutated some structure. MRSA happens due to mutation in MEK-A gene. Okay, mutation in something called as MEK-A gene, meaning penicillins are not working because there is this mutation, MEK-A gene. All right, is that clear? Now, next thing, we are talking cell wall inhibitor antibiotics, yes or no? Sir, in micro, you must have learned the cell wall of bacteria is made up of something called peptidoglycan. Peptides are present in the cell wall of the bacteria. There are two peptide bonds like this, lactate, they join together like, bricks, lactate. Okay. So now, sorry, my bad. Basically, here what happens is you have this bonds that are existing, peptide bonds. So what is happening is these peptides are being replaced now. For example, lactate and alanine. They were supposed to be something, but now what happened? They changed, they mutated. So this mutation that is happening here, that is alanine and lactate, this changes that are happening, it leads to one antibiotic resistance, and that's none other than your vancomycin. Okay, this has to be vancomycin. I hope all of you understood this thing here. Okay, hope this is clear to all of you. Next, now that we have learned this, let's move on to the next type of question. So, sir, the action potentials of ventricular muscle cells are recorded before and after administration of a drug. Which of the following antiarrhythmic drugs could it possibly be? All right. So, here we go. The answers are once again split. This requires a sound knowledge of this chapter to be answered. So if you have answered it correctly, bravo. Okay. So what is happening here? It's already given. Black curve is before giving the drug. Okay. Now you must remember this. In a ventricular curve, which ions play the major role? See, first of all, there are two main events. This first part is called depolarization, which is due to sodium. Next, this part is called repolarization. This is due to potassium. One thing you must notice is that after giving the drug, there is a problem coming in the depolarization. That's why there is a change in this area. And there is also a change happening in this area also now. Yes or no? That means this is a drug that is interfering both in sodium also, potassium also. Because it's interfering with both sodium and potassium, changes are happening in both the areas, yes or no? So which drug in this topic, I mean in this 4 drugs, can block both sodium and potassium? So class 1B drug lidocaine, it is a drug that blocks sodium plus it will open potassium. Okay, verapamil is a CCB, calcium channel blocker. Okay, calcium channel blocker. CCBs will have more role in the atria. Adenosine, it's a miscellaneous drug. It will not be coming in this picture. Now I'm left with procainamide. Sir, do you all remember procainamide comes in a class called class 1A? And what did I teach you class 1A does? Class 1A drugs, they block sodium, but in addition, they will also block potassium. Because the drug is blocking sodium, there is a shift that is happening like this. Because the drug is involved with potassium, there is again the shift happening like that. That means the correct answer is procainamide. And we also learned procainamide comes in the shipped drugs. Now let me ask you one last question. Any drug who tends to block potassium on the heart, can you tell me which arrhythmia can it lead to? Any drug blocking potassium leads to what? Okay. Guys. Okay. Dr. Nitesh Kumar got it. Awesome. Dr. Dopamine. Now you're getting that. Awesome. Any drug that blocks potassium channels on the heart, please remember they will cause torsades. And torsades, how do you see it on ECG? It leads to QT prolongation. From the chapter of arrhythmia, which drugs can do it? One is class 1A, another is class 3. Class 1A and class 3. They are going to do it. Why? Because class 1A is also blocking potassium. Class 3, so they are potassium channel blockers only. Yes or no? And how do you treat torsades? Magnesium sulfate. Okay, torsades, if it happens, let's say this arrhythmia happened in somebody, how do you treat the torsades? The answer is magnesium sulfate. Hope it is clear to all of you. Done? If you really understood, why don't you give it a try? I'm giving numbers to this. Number 1, number 2, number 3, number 4. Who's number 1? Anybody? Number 1. Which class of antiarrhythmic is number 1? Number 1 is something we just solved. Number 1 is class 1A. Why? Because it may be affecting sodium also. It may be affecting potassium also. Because it's blocking both, they're all getting delayed. Agree? Awesome. You guys got it now. Next. Class 1B, I told you, what do? They block sodium. Because they block sodium, this is happening. There is a delay. But they open potassium channel. Because they open potassium channel, what happens? The repolarization phase will happen little earlier now. See, if you block, it will take more time. But if you open, it will take less time. That's why this time it is going like this due to opening of potassium channel. Did you understand this? This is due to opening of potassium channel. Next, class 1C. Class 1C are primarily sodium blockers. Although they have a slight effect on potassium, let's consider it negligible at this point of time. To keep it simple in the brain, class 1A, sodium plus potassium blocker. Class 1B, sodium blocker plus potassium opener. Because it's opening the potassium, it's happening little earlier. Class 1C, let's consider pure sodium blocker. That's why you can see only the change here mainly. Okay. Now, come on, give it, give it a try. Number 4. Who is number 4? Dr. Anand. Dr. Anandu, you got it. Anandu Baiju, awesome. Dr. Pranita, Dr. Humera, correct. Awesome, awesome. So there's got to be potassium channel blocker. Why is it a potassium channel blocker? Why? Because only in the repolarization it's taking little more time. Okay, that's why it is this. चलिए boss. So any question expected on this? More or less we have solved this. Exam में आया तो गलत नहीं होना चाहिए. Okay, so awesome. Now we know these things. Let's go to the next one. 24-year-old male presents to the emergency department with a sudden onset of palpitation. He had an episode similar to this 1 year ago that resolved spontaneously. Rapid IV injection of a drug into the patient results in instantaneous resolution of the arrhythmia, but is accompanied with transitory flushing, burning in the chest, and shortness of breath. Which of the following drug was used to treat this patient's condition? Looking at your answers, क्या बात है, अति सुंदर. Awesome. Adenosine is the answer. Perfect, perfect, guys. So you're leaving nothing for me to teach. Good. They have said some palpitation happened. He had a similar episode 1 year ago. That means it's not continuous. It is paroxysmal. Yes or no? It is paroxysmal. So, sir, this is a case of PSVT. I told you this PSVT ka drug of choice is very important. They love to ask this. What is the drug of choice? Adenosine. Adenosine. All right. This is the guy. Extremely short half-life. It has a very, very short half-life. I told you that it is having such a short half-life. I want the drug to reach quickly to the heart. I will give it close to the heart. Remember, central veins. We are going to give this drug in the central veins. So this is one thing. So they are saying after giving the rapid IV drug, the person is getting okay. Rapid is also one more word. Normally IV is given through slow infusion, but here we give it rapid. Okay. All these exception things I have told you during the classes. Now the side effects are also given about adenosine. That means this whole para is about adenosine only. You get to see that flushing reaction, that vasoconstriction, bronchoconstriction can happen. All this are the side effects. So sir, bronchoconstriction, that's why don't use it in asthmatics, I told you. Now this drug is so short acting, so you can only use it in the hospital for the treatment. But how do you manage this long term if I need to give you a drug? Oral medicine which is longer acting, and that is verapamil. For the maintenance or prophylaxis, I am going to give the patient verapamil, but for the treatment, the drug is adenosine. Okay? So this was the question, my friends. Let's move on. 35-year-old woman with a history of schizophrenia is receiving treatment which has resulted in clinical improvement, including lessening of hallucinations. She was brought to the clinic with complaints of breast tenderness and no menstrual periods for 3 months. Lab studies, including the thyroid and pregnancy testing, are negative. Which of the following drug is most likely causing the presentation? So they are saying that patient was having hallucination, etc. So when I'm having hallucinations, etc., you must have diagnosed something, correct? I might be schizophrenic. And good news, it's already given here, schizophrenia. She was given some medicine. Now she's having breast tenderness, no menstrual periods, etc. Can you guys tell me kya hua hoga? What do you think must have happened here? Okay, I'm glad you guys are giving the correct answer. Yes, the answer is risperidone. Risperidone is the drug causing this problem. What has happened here? Why is all of these things happening? Sir, this is amenorrhea, no menstrual period, etc. Do you remember the relation of dopamine and prolactin? Important relation hai. When dopamine decreases, who decreases dopamine? Antipsychotic medications. Antipsychotic medications, they reduce dopamine. So you can expect two effects to come. One good, one bad. Think of it like that. Now, what is the good thing? Good thing is you will get anti-emetic effect. Good thing is anti-emetic effect. Okay. Next, you will get some bad effects. What are the bad effects when you block dopamine? The answer is, one of them is group of side effects known as EPS. Right? A group of side effects known as EPS, extra pyramidal side effect, almost a guaranteed question in exam. Next, they will be increase in the prolactin levels also, called hyperprolactinemia. Yaad aaya abhi? Reducing the dopamine will increase prolactin, and when prolactin increases, you will get amenorrhea. I told you prolactin inhibits GnRH, that's why you will get amenorrhea. And you will get, breast tenderness, etc. because of milk production. Are you all getting this? So basically, antipsychotic medication has caused increase in the prolactin levels. Okay, so let me ask you one question straightforward. These two drugs, they stimulate dopamine. To be precise, dopamine D2 receptors. Okay, D2 receptors. I'm simply asking you one question. If they stimulate dopamine, don't you think they will reduce prolactin levels? Are you with me on this? They will be reducing the prolactin levels. And that's where these drugs like cabergoline or bromocriptine, they will be used in the treatment of hyperprolactinemia. Sir, who can tell me between cabergoline and bromocriptine, which one is preferred in pregnancy? Pregnancy की drug of choice is bromocriptine. Bromocriptine is given in pregnancy, whereas cabergoline is given in non-pregnant people. ठीक है? Now that this is done, awesome. Next question, friends. 63-year-old man was diagnosed with type 2 DM 14 years ago. His current regimen includes glargine insulin. Recent test shows that his PPG levels are too high. PPG means postprandial glucose. Which of the types of insulin would be appropriate to add in this patient? Okay, so waiting for your answers. Now that you might have seen this, okay, some of you got the answer correct. In this, many of you got lost. The correct answer is injection of glulicine. Ladies and gentlemen, patient is already on glargine. What is glargine? Short or long acting, sir? हमेशा याद रखना, patient on insulin most likely will be on a long acting insulins because they are safer. This is already a long acting insulin. Why would you add another long acting? Degludec, Detimir, they are all long acting insulin only. Sir, after eating food, the sugar is increasing. That means, don't you think you should add the insulin called mealtime insulin? Mealtime insulin can easily reduce the postprandial glucose. तो कौन है? Who's the mealtime insulin? Mealtime insulin is injection of glulicine. Glulicine. चलिए, let me teach you this. I'll teach you this in a simple graphical format. All right. So there are two insulins I'm showing you. One insulin is like this, okay, and one insulin is like this. Now imagine this is number of hours, 0 hours से लेके 24 hours, okay. So 0 hours से 24 hours, okay. Now since you have gotten this idea, now check this out. This is around 5 hours, 4 to 5 hours. चलो 4 लिख देते हैं. 4 hours, 4 to 5 hours. One insulin is working only up till 4 hours. And one insulin is working up till 24 hours. So, अब आप बताओ, you think logically, which insulin do you think you can give in the maintenance? Throughout the day, one guy will maintain little insulin in your body, and that is long-acting insulin. So, long-acting insulins are these ones up till 24 hours. Who are these long-acting insulins? They are insulins like Detemir, Glargine, Digludec. ठीक है? They are all long-acting insulins. So they are always used in maintenance. One advantage, you don't have to take them 10 times a day. Take them only once a day because they work for one day, 24 hours. Okay. Some of them are more longer than one day also. Anyway, now next thing, what is the biggest advantage of long acting? Surgery, these ones, if you notice, they're not suddenly going at a very high level. If you're not getting a very high level of insulin, don't you think you will not get hypoglycemia? Yes or no? So these insulins are those that have less chances of hypoglycemia, less risk of hypoglycemia. Which insulins will have higher risk of hypoglycemia? Obviously, the ones which are tall like this. Obviously, this point at the top is called peak, and this insulins don't have a peak, hence they are also called peakless insulins. Long acting को क्या बोलेंगे? Peakless insulins, or also known as basal insulins. They maintain a basic level of insulin throughout the day. The one which is having the peak, my friends, will have a higher chances of hypoglycemia. Yes or no? So you shouldn't use them unless needed. Now the patient was already said that he is having too much of postprandial hyperglycemia. खाना खाने के बाद शुगर बढ़ रही है, right? After eating the food is, after eating the food, sugar is increasing. Now you must add such a insulin which can work only short period of time, give you that extra boost. आप पढ़ तो रहे हो, every day you're studying your notes and everything. You're attending this session, this is like a booster, right? Only if you need it, you're attending this. It's like that. So now if you see this, roughly 4-5 hours, people may have to eat their meals now. That's why these short-acting insulins are called mealtime insulin. Give it 15-20 minutes before a meal, the insulin will come or spike in your blood. Now when you eat the food, insulin will take care of that sugar that could have increased after eating. समझ आया सबको? Did you all understand this? You are keeping the soldiers ready in the blood before you eat only. So take this mealtime insulin before only. So I told you this is like very short acting insulin. Okay, short acting insulin, the moment you give them, quickly they will come into the blood. That means they don't have a lag. They don't have a lag. So this is what you can remember. So what is the lag mnemonic here? L for Lispro, A for Aspart, G for glulicine. These all insulins are called which insulins? Mealtime insulins. That means they are given before the meals. They are very short acting and they can be obviously useful for postprandial hyperglycemia. Here we are, sir. Okay. So अब आपने देख लिया, these are long acting insulins. I will not add them. Patient is already on the long acting. This is also intermediate acting insulin. I'm not going to add this. All right. Regular insulin, by the way, it is the only IV insulin in this list, and this one is given in the DKA patient. Okay, because it is IV, we can use it in the emergency. We give it in the DKA patients along with IV fluids. हो गया? Great. Sir, we are here to learn only. आज गलती करते हैं एग्जाम में नहीं. So that's why we are all here. Next, come on, let's go. 72-year-old male with atrial fibrillation has been on warfarin and metoprolol for a year. Few weeks after starting a new drug, he experiences sudden onset hemiplegia. Echocardiography reveals a small thrombus in the left atrium. The recently added drug was most likely. Okay, let me ask you one question. Guys, if you're having atrial fibrillation, what risk is there in this patient? If we don't give the drug for atrial fibrillation, what could potentially happen in the patient? I'm asking you. Monster hunk. I like your answer. ठीक है. Now, concepts. यही तो मामला है. We are revising the important stuff before the exam. ठीक है. Good. Some of you are saying stroke will happen. Correct. Atrial fibrillation increases the risk of stroke. ठीक है. Atrial fibrillation is there. This is all medicine, my friends. Internal medicine. Fibrillation increases the risk of stroke. That's why we put the patient on some drug so that the stroke doesn't happen. अब यहाँ पे क्या हुआ? Patient was already using some medicine to prevent the clot formation, etc. But even after taking the drug, clot has formed, and the stroke has happened. That's why there is hemiplegia. Let me ask you one thing. After taking the drug also, if the clot is forming, do you think there is toxicity of the drug or there is less effect of the drug? क्या हो रहा है in this situation? Dr. Ayush, you're close enough, but not correct. Okay. So now you check this out, sir. All right. Awesome. People have started answering. Less effect. I'm giving you a drug to stop the clot, but still the clot is forming. That means your drug is having less effect. चलो इसको क्वेश्चन को वापस आके आंसर करते हैं. All of you check this thing out. Something from general pharmacology. I don't know how many of you remember this. There are some enzymes in our liver that helps in metabolism, basically, let's say, to remove drugs. Keep it simple in the head. With these enzymes, I can remove the drugs. Now, what could happen is some drugs interfere with these enzymes. Some may increase these enzymes. Ab you decide and tell me. I want the answers quickly in my chat box. If enzymes are increased by these drugs, would you expect failure of drugs or will you expect toxicity? More enzyme to more enzyme to remove the drug is there in the body. Too much enzyme to remove the drug. What will happen? Toxicity or failure of the drugs? ठीक है. Enzyme inducers, what they're going to do is they will cause failure of drugs. They will cause failure of drugs. And if you don't have enzyme to remove the drug, because the enzymes are blocked in the body, समझ लो, there are enzymes to remove the drugs. If those enzymes are blocked, they are not there. That means it leads to what? Toxicity. तो एंजाइम इनहिबिटर से क्या होगा? टॉक्सिसिटी होगी. एंजाइम इंड्यूसर्स विल कॉज व्हाट? फेलियर. इज दैट अंडरस्टूड हियर? ओके. And don't you think if there is failure, you should compensate this? How can you compensate? Give more dose of the drug that is failing. So inducer mein, what is the compensation? Give more dose. That's what I want to do as a compensation. Give increased dose of the failing drug because its effect is coming less now. That's why I should give more dose. And the second thing is enzyme inhibitor mein, there is toxicity. So what do you think I should do? Give less dose. Give less dose. Inhibitor means they will reduce enzyme. आप याद रख लो, if the arrows are going down, that means the drug cannot be removed from the body. There is a risk of toxicity. What should you do as a doctor? Again, same arrow, reduce the dose. Look at the arrow. If there is an enzyme inducer, you should give more dose. You should give more dose. यहाँ तक तो गाड़ी आ गई. अब आप बताओ, patient was taking warfarin but still clots are forming. That means there is less effect of the drug. Answer got to be from the enzyme inducer, na? From this list, CRAP GPRS, okay, or CRAP GPS. And you know, this mnemonic, pure vitamin K cannot cause enzyme inhibition. Inhibitor की बात हो रही है. Inhibition is the mnemonic here. Okay. So obviously in the previous case there was failure of warfarin. Failure means it got to be somebody from the CRAP GPS. And if you check the list, this is none other than who, sir? Phenobarbital. All the other three drugs, you know, these three, they are all which type of drugs? They are inhibitors. Inhibitors will cause toxicity. Inhibitors will cause toxicity. And if you get, you know, warfarin toxicity, patient would come with bleeding. Okay, patient would come with bleeding. Sir, ये तो मैं समझा चुका. I hope you're not getting a doubt. This is the correct answer. Option C is the correct answer for this question. I am saying, what about the other drugs with warfarin? They could cause toxicity. And when you get warfarin toxicity, bleeding hogi. And how would you treat this bleeding? The answer will be, you will give something called vitamin K along with 4-factor complex. 4-factor complex. I hope you guys know something. Okay. 4-factor complex means what? The numbers which are reduced by warfarin will be present in that. That is 2, 7, 9, 10. Okay? 2, 7, 9, 10. I hope that is clear. So this is the whole, you know, discussion of the important topic of general pharma, inducers and inhibitors. Ho gaya, boss. Next. A 29-year-old man presented with blurred vision while cutting several trees in his garden. He has no history of illicit drug use. His temperature is 40 degrees. Blood pressure is 100 over something. Pulse is 110 per minute and respiratory rate is 20 per minute. Physical exam shows dry oral mucosa and dilated pupils. Which of the following drugs can reverse this patient condition? Alright, dosto. Buzzwords. At least from my classes, if you remember the thing, I always used to teach you dry word aate hi, you must remember parasympathetic system is blocked. Wet meaning more secretions. It is stimulation of parasympathetic. Dry means opposite of parasympathetic. ठीक है? Opposite of parasympathetic. That means here in this situation, there might be muscarinic blockade which leads to decrease in the parasympathetic functions. Parasympathetic kam ho gaya. Okay. Now, do you remember something like midriasis happens? Dumbbells ka ulta hota hai, opposite of dumbbells. Opposite of dumbbells. So that's how we used to learn this. So question to ab samajh aa gaya. That means somebody is reducing parasympathetic. Now, Do you all remember from our class what are the three poisons that can reduce parasympathetic? We used to learn them as bad. याद आया सबको? Bad. What is bad? One is belladonna toxicity, atropine toxicity, and datura toxicity. They all present the same way. They will do opposite of dumbbells. Example, midriasis. Okay, so that is happening. Now we know opposite of dumbbells, we get dry mouth, dry eyes, yes or no? So here we are. That means patient is suffering from something from this. Obviously, garden में atropine तो नहीं होगा sir. It has to be something like belladonna or datura. Okay, some poison may have been affecting this person. What is the antidote for the bad? Okay. Now that we have said this, antidote is naloxone. Okay, the antidote here is naloxone. Now, since this is done, okay, chaliye, this is a question. I'm hoping you guys answer. All right, so I was just telling you this. In this case, polycystic kidney disease is given in the, question. All right. Now, as you see this polycystic kidney disease, this is a hint that was given to remind you of something from internal medicine, that is berry aneurysm. Berry aneurysm, usually can be associated here, rupture of berry aneurysm, and subarachnoid hemorrhage is given for that reason. So, do you guys remember which medicine is used in the treatment of subarachnoid hemorrhage? This question was only about that. Okay, it's more of a medicine question rather than pharma here, but integrated question. Sir, in the subarachnoid hemorrhage, loud and clear, there is something written in the notes. There is a drug called nimodipine. Okay, do you all remember? There is a name called nimodipine. Nimodipine is a drug which works very well in the brain. That is the reason we use it in the subarachnoid hemorrhage for the spasms. Okay, there will be vasospasm that is happening in that situation. That's where we give nimodipine. So this was the correct answer for this. All right. Next, let's go. 30-year-old male presents to your clinic with wives. What? All right, I like this question already. He has poor vision. I can agree. He is having wives. Obviously, he has poor vision and a history of frequent falls. Looks like he falls for the women more often. Okay, Sarji, the question was actually supposed to say hives. Autocorrect. This is what it does. That's why human is always needed. Okay, गलती से mistake हो गया typing में. So, as you can see, there is a 30-year-old male presenting to your clinic with hives. You think it happened accidentally? So, anyway, I gave this question intentionally. Obviously, I know some of you won't even care about the diagnosis. You will be like, sir, he's having wives, so I'll give sildenafil. Ille, you shouldn't be doing that. My friends, the question is asking, this is a patient having hives, some allergy. What is the drug to be given if he is falling again and again? Don't give a sedative drug. Don't give a sedative drug. So what do? Give a least sedative drug. And which one is that? Fexofenadine. Okay, fexofenadine. Now, ladies and gentlemen, try and understand this logic. There are two types of antihistaminics. First generation antihistaminic, second generation antihistaminic. First generation antihistaminics, they can cause sedation. They can cause sedation, okay, quite heavily. Next, second generation, sedation is very less. Okay, less sedation or sometimes less to no sedation. From all the antihistaminics, the least sedative drug, it is fexofenadine. Okay. Now also remember, first generation have some extra property like antiemetic. Now there is a drug from this topic like promethazine, which can be used for motion sickness. Doxylamine, which can be used for morning sickness. Okay. These are all antihistaminics which are used as antiemetics. Is this clear to all of you? Obviously, I cannot give diphenhydramine. He is already falling. He will fall more. Promethazine, I cannot give. Again, same. They are all highly sedative. Sildenafil has no role here. Okay. That is an extra stuff that you can give. Okay. So, that's all about it. Anyway, if you want to give sildenafil, don't give it with a sedative ना भाई. ये क्या बंदा, ये क्या लॉजिक हुआ, बंदे को सुला दिया और कुछ कर दिया. तो you must give sildenafil when the dude is still alive, right? So anyway, now that we know the answer, what is the correct answer here? It is option C, fexofenadine. Fexofenadine. Now that this is over, 82-year-old female is brought to your clinic because of worsening forgetfulness over the past few years. You don't have to be 82 years to forget things. Sometime exam does it to us. And several recent episodes of getting lost while performing errands around the house. She is alert, cooperative, but disoriented to time and can only recall few things on short memory test. Brain MRI scan reveals cortical atrophy with no other abnormalities. This patient likely benefit from the treatment of which of the following? Obviously, by now, with all of that hints, you could have already diagnosed this guy is having a disease called Alzheimer. That is what is the diagnosis we could make from this. From this 4, which one is used in Alzheimer? The answer is aducanumab. Remember the A and the L. One is A for aducanumab, another is lecanemab. Alzheimer ka AL, right? Remember it like that. Alzheimer mein aducanumab and lecanemab. These are the newer drugs The mechanism being they block beta amyloid, which is causing Alzheimer. Okay, the problem that is causing the damage to the brain, that beta amyloid can be stopped by this drugs. Galcanezumab, okay, this is used in migraine. Okay, galcanezumab, etc. This is used in migraine. These are called CGRP blockers. Alirocumab, it is used in cholesterol issue. Okay, this is anti-hyperlipidemic. Denosumab, it is used in osteoporosis. It works on something known as rank ligand. Okay, now remember it like this. This guy has OS, this guy has OS, osteoporosis, denosumab. Okay, this one is anti-hyperlipidemic. That means it lowers cholesterol. So when you have over cholesterol means too much. Then we'll be giving alirocumab, galcanezumab, etc. You got to memorize that they are for the migraine. Okay, so girls को migraine होते रहता है, or they may give migraine also. Next is adacanumab or lecanemab, inhibits beta amyloid. Okay, inhibits beta amyloid. Okay, now that this is over, next, 8-year-old child is brought to the ER after a recent episode of loss of consciousness. His mother informed that he lost consciousness suddenly, fell on the floor, and started shaking and jerking. She also claims that her son has had episodes of staring in the space that occurred several times a day for the last year. The child is oriented in time and place. Which of the following agents is best long-term treatment for this patient? Okay, this is a question that I believe will be kind of having splits, but let's hope so. You guys get to the correct answer. The correct answer here is valproate. Okay. Now, why would I choose valproate even though there is another drug called ethosuximide in the option? So, they have already given you the hint of absent seizure in this. Person is staring in the space, etc. That means it is absent seizure. I told you the overall drug of choice is valproate. Now, another reason why I'm choosing this answer here is this. Okay. They have given one more hint in the question. The dude fell down shaking and jerking. That means most likely the child also have GTCS associated with absent seizure. Okay, GTCS bhi hai as well as absent seizure. Two things are there in this child. Sir, ethosuximide can be used only in absent seizure. It does not work for other seizures. Okay, it's a typical calcium channel blocker which is only useful in absent seizure. But this guy is having other things also now. So that is the reason I'll give you a wider spectrum drug which can correct everything. So which is the correct thing here? The answer is valproate. Okay, because the child is having GTCS along with this, I'm going to go with valproate as the answer. Cool. Next question. 38-year-old traveler presents to your office for a routine checkup. He'll be leaving for a cruise ship next week and asks for a drug that would prevent the severe nausea and vomiting he experiences on ships. After recommending the appropriate drug, you warn about which of the following side effects. All right, check this question. All right, so here we are, friends. Now, what you need to know in this topic is the drug that we are talking about is called scopolamine, also known as hyoscine, right? Scopolamine, also known as hyoscine. This is the medicine that we are talking about here. Done? If you talk about the mechanism of action of this drug, it happens to block muscarinic receptor. Because it is blocking muscarinic receptor, you must all get one idea clear, that is opposite of dumbbells. Opposite of dumbbells you're going to get. Now, when you say opposite of dumbbells, it's going to produce one thing called as antiemetic effect. And we already discussed this earlier that when you block the muscarinic receptor, opposite of dumbbells mein one of the feature is dry mouth. Okay, dry mouth. So this is the simple logic here. When you block muscarinic receptor, you're going to get dry mouth as the side effect. Scopolamine, when you're putting, you won't get a cough, nasal congestion, or a diarrhea. Opposite of dumbbells. Constipation may happen, but not diarrhea, sir. Okay. So that's it. You need to simply rule it out like this. Go, my friends. What's your answer in this? By now, you should have already figured it out. The correct answer to this is dutasteride. Okay, the patient is having dutasteride. I mean, this drug is dutasteride. So, what is the logic here? So, you must remember something. In BPH, there are two things that we needed to do. One is, what is BPH? Benign prostatic hyperplasia. Prostate has become bigger, that's why it's compressing your urethra. Because it's compressing the urethra, now you cannot urinate. Urinary retention is happening. So what do you need to do? Simply understand this logic here. One, we should reduce the size of the prostate. If prostate becomes smaller, this problem will be solved. But it takes time. Reducing the size of prostate is not like a 1-2 dose thing. It takes months to reduce the size of the prostate. So this is a good treatment, long-term treatment. But for quick symptomatic relief, I need to give you drugs like sildosin or tamsulosin. Sildosin or tamsulosin. These are the drugs that will be used in the treatment of symptomatic relief in BPH. Okay? Symptomatic relief in the BPH. Now, what about the other options here like doxazosin or terazosin? These guys, they need to be used only if the patient is having hypertension plus BPH. But again, BPH may it is only symptomatic relief. The only drug in this 4 drugs which can reduce the size of the prostate is finasteride or dutasteride. The drugs called 5-alpha reductase inhibitors. Okay, I really hope you remember this 5-alpha reductase inhibitors. That's the simple logic right here. Okay. A patient was recently diagnosed with asthma. He is also having hypertension and diabetes since last 7 years. He was started on the preferred bronchodilators. The patient is concerned about the possible side effects. Which of the following is least likely to occur? The correct answer, number 1, the patient is diagnosed with asthma. The preferred bronchodilators were given. What are the preferred bronchodilators for asthma? The answer is beta 2 agonist, sabalaba, salbutamol, salmeterol, formoterol, those kind of drugs. Now you must remember, when you stimulate beta 2 receptor, apart from getting bronchodilation as the main effect, there are many other effects of beta 2. Example, it can cause hyperglycemia, hypokalemia. Beta 2 receptor does this, hyperglycemia, hypokalemia. Next, it can do tremors also. It can do tremors also. So, if you knew this, still you could have answered. I'm sure many of you got stuck between palpitation and something. Okay. So, the correct answer here will be hyperkalemia, because it does not cause hyperkalemia. What does beta 2 receptor do? Hypokalemia. Beta 2 receptor drugs can reduce potassium. That's why they are useful in the treatment of hyperkalemia. Are you understanding? Because they reduce potassium, they're actually used in the treatment of hyperkalemia. So this is the correct answer. Even palpitations can happen when you use these medicines. Why? Because these are the drugs increasing sympathetic activity. When you increase stress wala system, fear fight wala system, obviously you will get palpitations also. So that's why the correct answer is this. Very important question, my friends. Okay. A 62-year-old woman who is a severe case of osteoarthritis is advised for a knee replacement surgery. On the day of surgery, she was given halothane. After some time, she developed a very high heart rate and her temperature is 41 degrees. So right now, she is very hot. Okay. What is the mechanism of the drug used in the management of this situation? Sir, what is this situation number 1? What do you call this? अरे भाई, आप लोग तो आंसर पूरे ही दे चुके, सिस्टम फाड़ देंगे. Very nice. The correct answer is dantrolene. But dantrolene का mechanism क्या है? What is the mechanism? Awesome. Full diagnosis, everything you're giving me. So, basically after giving halothane or succinylcholine, you usually may get something called as malignant hyperthermia. Awesome. So you guys gave me the diagnosis, malignant hyperthermia. But same hyperthermia can happen by using antipsychotics also. So when antipsychotic drugs do it, same thing only, just name will change. What will they call this now? Neuroleptic malignant syndrome, NMS. Neuroleptic malignant syndrome. Sir, it is the same thing, only the name has changed. Rishta wahi, soch nahi. Okay. So right now you're looking at this malignant hyperthermia, NMS, same thing, that is that hyperthermia that is happening. And you must know the drug that is given to treat whether it is NMS or malignant hyperthermia. It is a drug by the name of dantrolene. Dantrolene. So the drug is actually a ryanodine receptor blocker. Okay, ryanodine receptor blocker is called dantrolene. Okay, so I hope all of you got that. Please remember this. NMS or malignant hyperthermia, dantrolene is the answer. Okay, Dr. Vipul Saini is saying MMS. Exactly, when you watch MMS, you will be having smile on your face, you will be showing your teeth. Dant दिखते हैं ना. So dantrolene, that is the drug. Done. It is not a dopamine receptor blocker. Sir, the drug antipsychotic is a dopamine receptor blocker who can cause this problem. Okay. Next, muscarinic blocker. Muscarinic blocker is a drug like benztropine. Although benztropine is used in the treatment of EPS, but it's not this one. It is used in other things. What are the other things where you can use it, sir? Other things where you can use benztropine, the answer is muscular dystonia and drug-induced Parkinson. Make sure you all study this properly and go. EPS. EPSK, first of all, what are the drugs having more risk? Drugs are examples like haloperidol and risperidone. Haloperidol and risperidone. So this is what you need to know. These are the drugs who can cause this side effects in general, right? EPS. Next, if this EPS happens, you should know how to treat them also. I think I was clear just now. The dystonia that presents with torticollis, etc., it is treated by drugs like benzhexol. Benzhexol is also known as trihexyphenidyl. Trihexyphenidyl. Okay. Same drug is given here also. And I used to teach you, remember, Parcure benz. Same benztropine, benzhexol are used here. Akathisia, it is the motor restlessness of the patient, generally treated by propranolol, beta blocker like propranolol. Okay. Tardive dyskinesia, it is treated by medicines like this valbenzine. Valbenazine, etc. Okay. And NMS, we already just now said it is treated by dantrolene. Dantrolene. Okay. So these are the medications that you got to keep this on your fingertips. They love asking EPS, extrapyramidal side effects. Next, outside the box questions. That means apart from the EPS, you should also know weight gain, hyperprolactinemia. We already happened to discuss hyperprolactinemia. When you give antipsychotics, dopamine reduces, and because of this, prolactin increases. So the drug like risperidone, it is having maximum risk of hyperprolactinemia. Weight gain. Okay. So if you remember, if we are talking about weight gain, the idea is this. Weight gain will be by drugs like olanzapine and clozapine. Olanzapine and clozapine. Okay, these are the drugs with, highest weight gain. Okay, so you need to remember this. Highest weight gain is by olanzapine and clozapine. So I used to tell you this, that if you are traveling for small distance also by a cab, you will gain weight. Yes, you need to walk. If you're not walking, if you're always taking cabs, you will gain weight. So for close distance, if you take Ola all the time, that means you will gain weight. Okay, remember it like this, please. Next, I'm not promoting any brand. You go in whatever, sir. Okay, you go in Ola, Uber, Rapido, or your Yandex from Russia. I don't care. This is only for mnemonic. Next, if you're talking about those drugs that do not have weight gain, or they're more, let's say, weight neutral drugs. Weight neutral drugs. One is aripiprazole or ziprasidone. Okay, aripiprazole and ziprasidone, these are the weight neutral drugs. Okay, so I hope all of you got this. Very, very important slide. Expect a question from this. Awesome, sir. So we got a few more questions left. Come on, let's push through. 63-year-old man with a history of chronic hypertension coronary artery disease and a heart attack 3 years ago, presented with shortness of breath, fatigue, edema in feet, blah, blah, blah. Echocardiography showed EF, ejection fraction of 38%. BNP levels are also high. So which of the following would reduce the mortality in this patient? So this is the simple logic here. So if you've had coronary artery disease, there is always a risk of heart attack. And once you get a heart attack, you may get congestive heart failure. Already they have given me so many hints which are hinting me towards the CHF. Ejection fraction is also given 38%. So I know this is chronic CHF. This dude is a chronic CHF case. Now, I used to tell you in chronic CHF, give those drugs which can reduce mortality. Yeah, this mnemonic, all of you remember this? Super cool bhai saab, super cool bhai saab. These are the drugs that will reduce, cardiac mortality. One of them happens to be from the diabetes topic, anti-diabetic drug, that is gliflozins, SGLT2 inhibitors, because they make you lose sodium. If you lose sodium, you will have less load on the heart. All these drugs, they reduce workload of the heart. That's why they will make you live longer. Imagine a punctured tire. If you're still sitting on a punctured tire and going somewhere, it will burst only, no? So if something is failing, what do? Reduce the workload on that. Reduce the workload on that. So that is why these drugs are there, right? You're saving lives by giving the drugs. Nothing more cooler than this. Super cool, bhai saab. Okay. And beta blockers, which can be used. I mean, in general, beta blockers can be used, but these are more preferred. Bisoprolol, carvedilol, and metoprolol. Okay. So big risk of cardiac mortality. Big cardiac mortality risk will decrease by giving these drugs. Okay, big cardiac mortality risk will decrease by given this. Okay. Now that we have gotten this, okay. 37-year-old obese male consumes meat, seafood, beer on a regular basis. This dude is living his life. He has been recently diagnosed with hypertension, for which the patient is currently prescribed thiazides. He presented to the clinic with complaints of red swollen big toe. Fluid aspirins shows this yellow color needle shaped crystals which are negatively bright refringent. Which of the following drugs increases the uric acid excretion? All right. So here we go. The answer got split between A and C. A and C. The correct answer is option A. Question पूछ रहा है clear cut increases uric acid excretion. Sir ji, MCQs are like mutual funds. You all have seen the ad. Mutual funds investments are subjected to market risks. Please read all the scheme related documents before investing. ऐसे ही होता है. This is how the MCQs will be. You're not reading the document properly. You just saw the word gout, you got relaxed, you're like, question तो वही पूछेगा हमेशा allopurinol. Doctor साहब, question is clearly shouting, increases uric acid excretion. Okay. Now I hope all of you got that. Read all the MCQs like the mutual funds investment documents. नहीं तो ठोकर खाओगे. This is what will happen. Okay. Those mutual fund guys would be now looking at me and be like, chilla chilla ke scheme bata de, right? Like Akshay Kumar. So now if you see this, let's talk. This is the drug that increases uric acid excretion. This is called uricosuric drug. Febuxostat and allopurinol, they are the drug of choice. But which one is the drug of choice? Allopurinol. They are the drug of choice. What do? They will reduce the production of uric acid by blocking its production. How do they do that? By blocking one enzyme called xanthine oxidase. Okay, xanthine oxidase. What about colchicine? Colchicine is not used in the chronic gout. Colchicine is only used in the acute pain, that is acute gout. How does this drug work? It's used in acute gout. It blocks migration of neutrophils. If you block neutrophils from going somewhere, what is the logic, sir? Inflammation will reduce. Inflammation will reduce. So this is the simple logic right here. Done. Answer is probenecid for this reason. Also remember one or two drugs from this. There is drugs like rasburicase. Okay, rasburicase and pegloticase. What do these guys do? Rasburicase, pegloticase, they will break down your uric acid. Uric acid will be broken down by these drugs into something called allantoin. So these drugs, they can do this. They can promote the breakdown of uric acid to allantoin. And how can they do that? By an enzyme called uricase. They stimulate uricase. इसका तो नाम यहीं पे दिख रहा है ना, uricase name. Okay, so you can see it right here, and they basically do something called oxidation reaction by which they are going to break down the uric acid. And these drugs like rasburicase, pegloticase, they are primarily used where? These drugs are used in the treatment of TLS, tumor lysis syndrome. Okay, tumor lysis syndrome. So that is the simple logic right here, sir. Done? Come on, another very repeated topic in the exam hall. Women presented to the OPD with complaints of severe throbbing headache, which is accompanied by nausea and sensitivity to light and sound. Before the onset of the above symptoms, the woman usually sees bright flashes of light, numbness, pins and needle sensation. Which of the following drugs can cause gangrene in the fingers? All right, looks like some of you took the mutual fund example little seriously. Now you got it correct. The correct answer is ergotamine. I did not ask you the drug of choice. Question में लिखा था which drug causes gangrene. If you remember the mnemonic, ergots are those drugs. Ergots, rods, fingers. Remember I told you this the mnemonic, ergots, rods, fingers. So these are the ergot and drugs that we use here. And usually the treatment that we can give for this is nitroprusside. The vasoconstriction is causing gangrene, so how can you prevent that? By vasodilator drug like nitroprusside. That's why the answer is this. Migraine ka prevention, the best drug is propranolol. Treatment, if it is mild to moderate, I'm going to use NSAIDs. Okay, NSAIDs are going to be used for mild to moderate pain. But if it is severe, then I'm going to give you triptans. but triptans are contraindicated in MI, ischemic heart diseases. We should not use triptans. So what do we go for when it comes to this situation? The answer is lasmiditan. Lasmiditan. I used to teach you the mnemonic less MI. This is the drug that gives you less MI. That is lasmiditan. Lasmiditan. ठीक है? Go ahead, sir. A 30-year-old pregnant female in her first trimester met with an accident on her motorbike. X-ray showed fracture of femur and tibia and damage to the joint. She had to undergo a joint replacement surgery and 2 weeks later developed shortness of breath, chest pain, hemoptysis, pain in the calf muscle. Blood tests show some levels to be elevated. What drug should be used in the management of this present situation? Correct answer is this, heparins. Okay, low molecular weight heparin. This will be our correct answer in this. Guys, the patient may have developed DVT because she had a fracture of this areas. Maybe she was not motile, and you know, when you're not moving, then there is risk of clot formation, like in the DVT, and this DVT may convert to pulmonary embolism. That is the reason you're seeing this kind of symptoms which are from the lungs. So in this situation, what do you give in the treatment is, heparins, low molecular weight heparins. Now, let me give you one clarity on this topic. Okay. See, when you're talking about hospital management, that is treatment of this kind of, thrombus, etc., venous thrombosis, I will always prefer heparin in the treatment, specifically the low molecular weight heparins. Done? Now, after we said this, how about the prevention part? If you talk about prevention, okay, if you talk about the prevention part, we should go for the drugs known as DOACs. Okay, we should go for the medicines known as DOACs. So what is DOACs? DOACs means direct oral anticoagulants. These are those medications simply known as what? Direct oral anticoagulants. Now, who comes in this? Example, factor 10A inhibitors like Exabans, and you also got, somebody called factor 2 inhibitor called dabigatran. Okay, thrombin antagonist. Number 2 is called thrombin, so we call it thrombin antagonist. Okay, I hope this is reasonable enough for all of you. So ये drugs को क्या बोलते हैं? DOACs. DOACs means direct oral anticoagulant. Sir, oral drugs are preferred in the management. Long-term management is always by the DOAC type of drugs. Cool. Now, since we said all these things, now we'll move further. Usually they love to ask something in the pregnancy in this topic. Now, what is another oral drug, but we don't prefer it? Okay. Another oral drug which we use is called warfarin. But today we don't prefer warfarin. Practically speaking, we use warfarin only in one place, in those people who are having mechanical valves. Are you understanding what I'm saying? We should only prefer warfarin in patients having what? Mechanical valves. Now that we set this idea, okay, let me take you further down. Preferred कौन है? Who's the preferred drugs today overall for anticoagulation? They are DOACs. They are the drug of choice. Except in mechanical valves, that's where you will prefer warfarin. WM ulta hai. At least remember it like that. But now if you talk pregnancy, what is the story? Try and understand this logic also, please, right? What is the story of pregnancy? First of all, if they mention pregnancy, always and always will prefer this idea, that is, heparins are always better. First trimester, That means in the first trimester, who am I using, my friends? In the first trimester, my preferred choice is none other than heparin. Let it be UFH, let it be low molecular weight heparin. Now, next thing is second and third trimester. Okay, second and third trimester. If you're talking about second also, third also, whatever it is, let's try to understand this. Here again, heparins I'm going to prefer here. Second and third, maybe the drug of choice is heparin only. Okay, I hope it is clear to all of you. Warfarin is only used in those females who are having mechanical valves in the heart. Okay, I'm going to use warfarin only in patients, pregnant females having mechanical valve. Nahi to I will still prefer heparin only. So let's say they specifically mention there is a female having some mechanical valves, etc. So heparin is the best drug in that also, but in case you want to use the alternative, it is warfarin. I told you. Okay? Warfarin cannot be used in the first trimester because it is teratogenic. So agar use karna hi hai, if you want to use this, then this is what we are going to do. Okay? And warfarin again, we need to discontinue this after 36 weeks. So after 36 weeks, okay, again you need to go back to heparin. Okay, so all the time heparin is the preferred medication. Okay, heparin becomes a patient complains of muscle weakness that becomes progressively worse during the periods of physical activity and improves after period of rest. Typically the weakness is worse towards the end of the day. All right, I'm sure by now itself you have already diagnosed it's a case of myasthenia gravis. Okay, now if you check this, myasthenia gravis patients come like this with ptosis because their muscles are relaxed. Relaxed muscle presence like this. You give a drug that contracts the muscle. It contracts the muscle like this. The eyelid opens. All right. So here we go. The name of the test is called tensilon test. We give a short-acting drug called edrophonium. Edrophonium happens to be a short-acting drug. Okay, it's a short-acting drug. Now the mainstay of the treatment here, it is going to be a drug called pyridostigmine. Okay, pyridostigmine, that is the mainstay of the treatment. To prevent the side effects of pyridostigmine that could be caused, we add atropine. This is given to prevent muscarinic side effects. Atropine does not have any role in myasthenia. When you give pyridostigmine or neostigmine, what happens? There will be some side effects coming. Those side effects can be prevented by atropine. Okay, so this is for the logic. Treatment, यहाँ पर question में क्या पूछा था? What could be the possible management of this patient? The answer is pyridostigmine plus atropine. Some of you may argue, sir, what if C and D are given? I gave you intentionally. I gave you best pucha hai na, so I will be choosing this as the answer. Okay, so this is it. Next is 52-year-old patient with severe history of asthma presented with complaints of severe ocular pain, redness, decreased vision, etc., etc. Vision is decreased. There is sudden increase in the intraocular pressure. Okay. Around 50 mm was noted. Which of the following should be avoided in this patient? Okay, I will cut this question. Now choose your answer, please. I've changed the question. I want the answer for the changed question. Now the correct answer will be latanoprost. Why latanoprost? Because they have given the word inflammation. Okay, inflammation. So, sir, try to understand this. Latanoprost, prost word is there. Prost means they are prostaglandins, and prostaglandins will increase inflammation. Prostaglandins will increase inflammation. That is the reason you should avoid them if there is already some inflammation. All right. Although Prost drugs are mainly the drug of choice in the open angle glaucoma, as we may all be knowing. Okay. So this is what is the correct answer for that reason, sir. Next is a 52-year-old patient who is currently on metformin with HbA1c value 7.2, had an MI 3 years ago. Further cardiac evaluation shows ejection fraction is less. BMI is something, blood pressure so and so. His creatinine level is this. Which is the most appropriate medication to be added in the regimen of this patient? I think I don't need to wait for this question. You already must be knowing gliflozins. I told you gliflozins are actually the drugs of diabetes which are now used even in the heart failure. As for sodium loss is good for the heart failure patient. Glucose loss will be useful in the diabetes patient. So this is the logic. Gliflozin, you must remember this, sir. Glucose flows in urine mnemonic. I used to teach you, right? So glucose flows in urine. Anyway, apart from this, I would recommend that you watch even the last wala 25 important question video. There I didn't put much questions, but I discussed a lot of concepts, important side effects, etc. etc. Okay. So I would strongly recommend and suggest that you guys watch that also. Watch it at 2x speed. Quickly finish that today itself if you can. Okay. You will definitely benefit out of this. एक से दो बार repeat. There will be some repeat topics. Whatever is repeat, if you feel so, just quickly move on from that. You won't even spend that much time. ठीक है. But कर लेते हैं because touch wood, I am telling you, a lot of times questions have shown up from these videos that we are doing right now. And you don't want to repent later when the time is gone. आज देख लो, फायदे में रहोगे. ठीक है. Now, since we said this, next part says if you talk about the side effects. Okay. Sir, hypoglycemia, which anti-diabetic drugs do it? One is obviously insulin will do it, no doubt, especially which ones are short-acting insulins. याद है short lag वाला था. Next is drugs called sulfonylureas. Sulfonylureas, they will do the weight loss. I mean, hypoglycemia. Next, weight loss, if you talk about, then we have these drugs called GLP-1 agonist. Okay, GLP-1 agonist. Drugs like semaglutide, etc., the famous one these days for the weight loss. Okay, I told you brands like Ribelsis or Ozempic, these are the semaglutide. Okay, now that we got this GLP-1 agonist, next is SGLT2 blockers. Okay, at least one or two we can remember. The whole list you can refer from the main workbook. I'm just reminding you last minute mein main number 1, number 2. Think of it like that. If you add, there are more drugs in the list like pramlintide, etc. also. Okay. Lactic acidosis is an important side effect of metformin. Metformin causes. Because of lactic acidosis, metformin should be avoided in the renal failure patient. Flatulence and diarrhea will be seen by alpha glucosidase inhibitors, example acarbose. Acarbose. What I used to teach you back then, acarbose means when you take these drugs, there will be absence of carbs in your blood. Why is there absence of carbs in your blood? Because they're getting lost. You eat from here, you lose it from the other end. That's why diarrhea gases. UTI genital infections, this happens by, putting this glucose into the blood. This is by the SGLT2 blockers. Okay, SGLT2 blockers, and these are the medications that we call by the name of gliflozins. All right, so these are the simple medications by the name of gliflozins, SGLT2 blockers. Okay, so more or less we end the topic right here, my friends. Okay, so you attended this live, great. Those who are going to watch this later, again, you can watch it at a higher speed. Even if you have attended this live right now, please do re-refer to this quickly. जो basic mistakes point है ना, that you can quickly revise. If you can do it from the PDF alone, which I'll be sharing, that is good enough. If not, revisit the video at a 2x speed. Some topics which you already know, skip them. If not, come back and watch this quickly. Last 2-3 videos देख के जाओ, and I pray that you guys get questions from this and you will be happy after this. All right, Baki, good luck. Share me your good news once you pass the exam. All right, नहीं भी हुआ तो कोई बात नहीं, we are going to stick together and get this thing done with. ठीक है, always remember, when you're going towards a destination, when the red light comes, that doesn't mean it's a permanent stop for you. It is just a temporary stop. So anyway, we wouldn't think on those aspects. We will think we are going to reach the destination by hook or crook. We'll take a good attitude on the day of exam, and God willing, you're going to pass. All your hard work is being watched right now. Nature will bless your hard work soon enough. Okay, all of us are waiting for your good results to come. God bless all of you. Happy New Year to all of you, by the way. Hope this new year brings you all this success. And I get to hear this, कि sir, मजा आ गया एग्जाम में. All right, 200 पार लेकर आना है दोस्तों, ठीक है? Hoping all of you do that. So some questions, one or two that you're asking me to repeat, sir, this is already on YouTube. You can go back, refer to it again. All right, so that's something that you can do. Cool. So take care, sir. Sir, cardioversion, the thing you're asking me, I don't want to poke my nose into that. That's a medicine thing. You can ask your medicine faculty when to do cardioversion. Okay, I'll only talk about my drugs topic. That's it. Okay, चलिए चलते हैं फिर. Hopefully मिलेंगे. I get to hear the good stories, as I said. Take care, everybody. Bye bye.